Good morning, everyone, and welcome to today's webinar, LGBTQ plus family building. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Additionally, we encourage you to submit questions to Dr. Resetkova using the question section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer session at the end of today's presentation. Now, without further ado, I would like to introduce today's speaker. Dr. Nina Resetkova is a reproductive endocrinologist at Boston IVF and a member of the American Society of Reproductive Medicine and the New England Fertility Society. Her research interests include the application of cost-effectiveness studies in medicine, studying the RNA profile of developing embryo, and LGBTQ plus family building. Dr. Resetkova sees a wide spectrum of fertility patients, including those who would like to explore fertility options and fertility preservation. She has a special interest in caring for the LGBTQ plus patient population. Her novel research examining transgender fertility preservation outcomes has been published in peer-reviewed journals and presented at national meetings, receiving significant interest from the press. All right, we're going to get started. I'm going to pass it over to Dr. Resetkova.
Thanks so much for the introduction and welcome everyone. Hope you're all enjoying this weather we've been having, hopefully a little bit of sunshine coming out in the next portion of the week, and happy Pride Month to everybody as well. As Alyssa mentioned, I'm here to talk to you about a special interest of mine, LGBTQ plus family building. I am a reproductive endocrinologist at Boston IVF. I've been with the group here for about 9 years, and I see patients in the Boston Center and then a wide range of other locations, including some in the South Shore and some north of Boston as well. So welcome. A couple of disclosures, none of which should affect our discussion today. So the objectives for today's talk are going to be to learn more about the various treatment options available for LGBTQ plus individuals and couples. We're also going to talk about some studies that we've done at Boston IVF looking at reproductive outcomes for LGBTQ individuals, and particularly review some of our transgender fertility preservation data, and also some patient management and clinical recommendations. And I welcome some questions as well from the audience today. We do have a hard stop around 12:50, so I'll be mindful of the time just to leave enough time to answer any of your questions from today. Look forward to those. All right, so just to give a little bit of a backdrop to our discussion today, we're going to be talking about care for LGBTQ plus patients, and it has a wide spanning terminology. Some new data actually from a Gallup poll from last year is that this actually represents about 7.2% of adult Americans. So it's pretty wide spanning. And since they actually do a regular survey since the last 10 years, that population or percentage has actually doubled. So a lot more people are identifying as members of this community. In addition to that, about 0.6% of US adults identify as transgender, so that is a subportion of the 7%. You can see here a heat map across the country of the areas or regions of the country where that percentage is the highest. So you can see kind of the coasts are a little bit more predominant in an LGBTQ population, and certainly we are one of those states as well, in Massachusetts and also New York for anybody who's joining on from a wider region. In our community, in particular at Boston IVF, we have a selected patient population because a lot of our LGBTQ patients will need our center in order to help build their families. So in our patient population, we see approximately 10% of folks identifying as LGBTQ. And we've also seen some changes over time with that approximately doubling over the last 10 years, very similar to the Gallup poll. So there are some specific needs of this community. Firstly, respect, like all patients who deserve respect, and recognition of their relationship status. Of course, an understanding of the correct pronouns and terminology, using their preferred pronouns, asking about those, having neutral questionnaires that patients can fill out so that, their first impressions really as they engage with the practice are positive and inclusive. They want to have availability of certain procedures and experience with certain procedures. And at our center, we've been caring for the LGBTQ population since our inception. So we certainly have a lot of experience in working with individuals and couples, really partnering with them in the process of family building. It's important also to review all available treatment options with patients, including some options that may not necessarily be preferred, but some that they are aware of all different options that are available to them. And sometimes that involves kind of thinking outside of the box and assessing what reproductive organs are available in order to achieve their goals, and sometimes for both partners to be intimately involved in the process of family building. So today we're going to talk about fertility treatment, but also fertility preservation. We're going to talk about treatment options for lesbian patients, gay patients, and transgender and non-binary patients as well. So some of the trends, as I shared with you, we've seen some increasing proportion of our patients proceeding with as essentially as same-sex couples. This is same-sex female couples as a percentage of all treatment cycles. You can see that we're almost at the 9% range as of 2021. So those numbers have really increased over time. So in terms of the first sort of treatment option we're going to talk about for same-sex female couples, we're going to talk about donor insemination. Now, folks can choose to do this at home outside of the office setting, or they can choose to do it in the office setting. And what's important to note is that it's more successful not only after a full fertility evaluation, but also more successful when the sperm is actually able to be inseminated into the uterus versus at home, when typically couples will use a kind of vaginal insemination or intracervical insemination. So the reason for this is that the full fertility workup allows us to understand whether there's any fallopian tube factors that may be contributing to the chances of success. It also allows us to understand whether there's any concomitant ovulatory disorders or anatomic abnormalities or endometriosis, uterine fibroids, et cetera. So we're able to appropriately select the treatment pathway. Plus, with intrauterine insemination, there's a higher percentage or higher proportion of the sperm that's actually entering the reproductive tract. And generally speaking, with a good, strong vial of sperm, we're seeing about 5 to 10 million sperm that are being inseminated into the upper portion of the uterus. So the chances of success are increased with that as well. A very general approach is for patients who are under 35 years of age. We would recommend up to 6 cycles of insemination, and probably somewhere between 3 to 6 cycles for patients over the age of 35. Best success rates are about 3 to 4, and then the cumulative success rates beyond that point are marginally not as high as the earlier cycles. Now, of course, we can do treatment using a medicated approach or an unmedicated approach. For folks who have regular cycles, we typically recommend unmedicated at the beginning, because adding in Clomid or letrozole may not increase success rates per cycle in any sort of a significant way, but may and certainly does increase the risk of twin and triple pregnancy. So typical approach is to start with an unmedicated cycle and then add in medication, or add medication if needed to enhance ovulation. Some data for you on donor insemination. This is an older study that was published in the year 2000, looking at donor insemination, comparing single women to lesbian couples. There were 675 cycles that were performed in single women, and then 139 cycles performed in the study for lesbian couples. The same-sex female patients were younger, 34 years of age, compared to the single women who were a little bit older at the start of their journey at age 38. And we might expect that the clinical pregnancy rates would be influenced with that. So the clinical pregnancy rates were 36% in single women and 57% in same-sex female couples. And the cumulative pregnancy rates were higher in the lesbian couples as well. Miscarriage rates were lower in the same-sex female couples, likely because of age, starting at age 34 to 35 as opposed to 38 to 39. So cumulative outcomes, again, higher in lesbian couples. This study has been done sort of on a larger scale out of a California-based clinic published in 2021, and they looked at IUI cycles for approximately a 10-year span. 11,000 cycles were included, 393 of which were in same-sex female couples and 11,000 in heterosexual couples. And interestingly, in this group, again, in a kind of a West Coast demographic, the average age was pretty similar amongst the group, so about 36. And the lesbian patients had a positive pregnancy rate that was higher per cycle than the heterosexual rates. And interestingly, for this population, the miscarriage rate was a little bit higher. The miscarriage rate was lower for the lesbian patients, kind of like the heterosexual patients. And when they did multivariable logistic regression, the lesbian group had higher odds of clinical pregnancy. And what this shows us is that in the heterosexual couples, typically they're presenting with a history of infertility. So that may be influencing their overall success rate. And sometimes IUI is used for a mild male factor infertility as well. So for lesbian patients who are either working with a known sperm donor or an anonymous sperm donor, typically the sperm parameters are going to be very, very good for that population. And without a prior history of infertility, the success rates are going to be a little bit higher as well. These were the data tables from this particular study. And interestingly, we looked at our own patient population, looking at patients of all ages undergoing donor sperm insemination in female-female couples. And we found that a very similar story with the success rates, about 42 to 43% across multiple cycles. As you can see on this in this data, after the 6th treatment cycle, there really isn't a significant increase in the overall success rates. So even for younger patients, we would generally recommend picking a more aggressive modality for treatment if not successful after the 6th treatment cycle. A couple of notes on donor insemination. Firstly, it's very well tolerated. So the risk of any complications with insemination is very low. The sperm is processed beforehand to strip any proteins, so the risk of sort of a chemical irritation is extremely low. Some patients have a little bit of cramping, but that usually resolves after the procedure. And the procedure itself takes a couple of minutes to do. At our center, it's performed at our Waltham Center because that's where our sperm is stored. So we'll thaw 1 vial of donor sperm per insemination, and then the procedure will take place there the same day. The average cost of a vial of sperm, still about this price point, about $800 to $1,000. It depends a little bit on the sperm bank, how many vials you're purchasing at one time, and then the shipping costs can vary as well, usually a couple $100s. Most patients are encouraged just to purchase several vials at one time, maybe 2 to 4 vials, just to cut down on shipping costs. And we do have some sperm available from Seattle Sperm Bank on site at Boston IVF, so the patients can choose a donor from there and reduce some shipping costs as well. The average cost of an insemination can vary a little bit, varies based on whether there's monitoring that's being done during the cycle and whether there's any medications that are used. So I provided kind of a range here, $500 to $1,400 per cycle, but we are seeing a lot more coverage for insemination for single parents by choice and also same-sex couples. So a lot of the insurers are stepping in and covering for treatment at an earlier point in their course of treatment, or even entirely at the beginning of their journey. Choosing an anonymous sperm donor is faster than somebody working with a known sperm donor because there isn't that quarantine period. So if there's any time sensitivity to treatment, I always recommend that patients consider moving forward with anonymous sperm donation because they can cut out that 3 to 6 months of quarantining sperm. If a couple or an individual are not pregnant after 3 to 6 treatment cycles, then IVF is generally recommended. And the chances of success for IVF treatment are highly dependent on age. For under age 35, success rates are very good, about 40 to 50% per treatment cycle. And then they do drop off a little bit with increasing age, but generally still fantastic cumulative success rates under age 40. There's a lot of question to whether we should be doing 1 IUI per cycle or whether we should be doing 2 IUIs. This has been looked at in multiple studies. I included one here from 2019. And interestingly, the success rates are not statistically significant if you're looking at doing 2 IUIs in one cycle or 1 IUI. But if you do choose to do 2, which sometimes I consider for my patients who are doing kind of a closure cycle of IUI before moving forward to IVF treatment, the best approach would be to do one essentially the day prior to ovulation and then one on the presumed day of ovulation, so that there is some additional sperm present in the reproductive tract. And this can be done using ovulation kit testing or more precisely using monitoring at an IVF clinic and using a trigger shot to help better narrow in on those 2 days. Today, we're also going to talk a little bit about partner-assisted reproduction. This has many different forms of nomenclature. So if you read about it, you might read about reciprocal IVF, as it's often called. There are also terminology like ROPA, ROPA, or potentially even shared motherhood IVF. So it's been called different things, but essentially it's a process where 2 same-sex female partners are undergoing a very intimate role in this process. One partner undergoes ovarian stimulation for egg retrieval. So this is a partner who must have ovaries. And then the second partner undergoes preparation of the uterine lining for embryo transfer. So this partner needs to have a uterus. But it is an interesting option for individuals where they have not had one partner has not had good response to ovarian stimulation or potentially failed IVF cycles previously. And then the other partner who may not wish to carry the pregnancy still has good ovarian function and will undergo the stimulation, ultimately egg retrieval, and then embryos are created with the use of donor sperm, and the second partner receives the embryo. This can all be coordinated in one cycle, so it can be done over the course of 1 month, or more commonly, it's done over the process of 1 to 2 months, so that we have the outcome of the first cycle. We understand how many embryos have been created, what is the quality of those embryos, potentially even the genetic testing of those embryos, if chosen, and we can discuss those and make a plan for embryo transfer. Almost exclusively, we're doing single embryo transfer for this patient population, particularly with the use of genetic testing of embryos, therefore decreasing the risk of pregnancy complications, such as the risk of multiples. Obviously, really amazing opportunity for involvement of both partners, and sometimes this is sort of medically indicated just because of prior IVF failure for a partner or potentially missing anatomy such that both partners need to be involved. It's typically more expensive than insemination, and we are seeing some more insurance coverage available for this pathway also, but largely it is still an out-of-pocket expense for most couples. Just a little illustration here of the components that are necessary for this type of treatment. And then in terms of success rate, I will say there's a lot more data that's been coming out in LGBTQ fertility. There's been a lot more studies that have come out over the course of the last 3 or 4 years since I've been speaking on this topic. This just a few years ago was really the best available study that was available on reciprocal IVF or partner-assisted reproduction. As you can see here, they call this procedure shared motherhood IVF. This is a study published out of the UK, and they looked at 172 cycles in a 6-year period of time. They actually did most of their cycles as synchronous cycles, meaning that the embryos were created and transferred into the partner in the same treatment cycle without the embryo undergoing freezing. And what was interesting about this particular clinic is they had a lot of sort of reproductive tourism. So we had a lot of people coming in from other countries in Europe to have treatment with them. In this study, 58% of patients underwent single embryo transfer. As I mentioned, it was over a 6-year period of time, and they noted that there was a lot more single embryo transfer happening over the course of the latter years of the study, as has been going on in our field. And in the study, they had a cumulative live birth rate of 60%, with 14% being twin pregnancies. So we've had the opportunity to study this also at Boston IVF and have submitted our research to national conference at the ASRM, spoken on this topic, and then also have submitted for publication. And we call this technology co-IVF, our nomenclature. And in fact, we noted when we compared the co-IVF success rates to our heterosexual couples undergoing IVF treatment, that the success rates were better, even in comparison to using egg donation. So we have some very high success rates with live birth rates at 57%. In this group. And we've also done a follow-up study to look at this and noted that the time to pregnancy is also faster than conventional IVF for heterosexual couples and those proceeding with egg donation. So it seems to be a great treatment option, and still more data forthcoming, maybe that I'll share with you next year if you log on, about some more data in this co-IVF patient population. Of course, some alternative forms of family building like egg donation and surrogacy are also available for lesbian couples. In some cases, those are indicated just based on prior treatments, and then not being a good candidate for carrying pregnancy. But we won't go too much into those topics today. If you have any specific questions, again, feel free to voice those and we'll try to get to them before the end of today's talk. So for gay male couples, obviously they typically have sperm, and typically both partners will be sperm producing, but they do need some help with eggs and also somebody to carry the pregnancy. And so in terms of the egg donor and the gestational carrier, they may be working with somebody whom they know, so somebody who's known to them, or something that we used to call anonymous, maybe not, anonymous is probably not the best terminology any longer. We typically say non-identified at this time because, of course, with egg donation and then the wider propensity for folks to look at a 23andMe or Ancestry, there is a possibility of some identification in the future. So non-identified is typically the preferred terminology. But if they don't have anybody who they want to work with from their family, for example, or close friends, they would typically work with an agency to recruit an egg donor or gestational carrier. There is a lot of need for legal oversight, and typically working with the agency is some reproductive attorneys who can help with this process. Of course, a social work evaluation is needed, so some sort of psychosocial evaluation is very important, and that's important for the intended parents. It's also very important for the egg donor and the gestational surrogate candidate to make sure that the interests are aligned and then that there's no kind of coercion that's taking place. Egg donation can happen in multiple ways. As I mentioned, it can be with somebody whom they know, or it can be a non-identified egg donor. And eggs can be previously frozen and they can be purchased from an egg bank, or they can be in the setting of a fresh cycle where an egg donor will go through the process of taking injections and have an egg retrieval, and then all those eggs will then come to that intended parent couple for the purpose of creating embryos. In this process, both men typically wish to be biological parents. I have had some cases where only one partner chooses to do so, but in most cases, we're actually splitting the egg lot and inseminating the eggs, half with one partner's sperm and half with the other partner's sperm, so that we can create embryos for both. In terms of surrogacy, there's a couple different approaches to surrogacy. Number one is traditional surrogacy, meaning that the eggs and the eggs are coming from the same person who's carrying the pregnancy. That is not widely practiced in the United States because there are no protections in place for the intended parents. So typically in the United States, there are legal protections in most states for gestational surrogacy, where the person who is carrying the pregnancy, those eggs are not biologically hers. Surrogacy laws are becoming more favorable throughout the country. As you can see, a lot of green on this map, but there are some states where you should avoid proceeding with surrogacy because, again, there are no protections in place for the intended parents. New York used to be one of those states, but now it is permitted, and there are some new laws with protections in place. Massachusetts is pretty good, but there's still some work to be done. Our neighboring states in New England have actually have even more protections in place than Massachusetts. We are working on some parentage laws in Massachusetts that should help over the next couple of years. Success rates with surrogacy, particularly for male-male couples where presumably sperm function is very good and there's no history of infertility with the use of that sperm. And typically the egg donor is going to be somebody in her 20s or early 30s, and the gestational carrier, somebody who has safely carried pregnancy to term with good prior implantation. Success rates are very optimized. They can be as high as 60 to 70% per embryo transfer. Therefore, most couples will be pregnant on the first or the second embryo transfer. In very rare cases are additional transfers needed beyond that point. We strongly advocate for single embryo transfer to reduce the burden of prematurity and any adverse outcomes from twin pregnancy. And of course, for protection of the surrogate candidate as well. Treatment is costly. And I think one thing to know about this is that also there's a strong timeline component. Usually it takes about 12 to 18 months to be matched with a surrogate candidate. So, costly of time and financially costly as well, typically well over $100,000 for working with an agency. If somebody has a candidate in mind or somebody from their family or friend group is willing to carry the pregnancy, the treatment would then be much less costly. And interestingly, some employers are offering some benefits that extend to surrogacy and even adoption, alternative forms of family building, which is wonderful. Moving on to working with our transgender patient group. We're going to talk a little bit today about folks that are assigned male at birth and the fertility preservation or treatment options that are available for them. And then spend a little bit more time talking about individuals assigned female at birth. And then I'll share with you some outcomes from a Boston IVF internal study. So this little bar graph was put together last year, so it doesn't have full data looking at 2021 and 2022. But as you can see here, our transgender patient volume has really increased over the years. Not sure what happened in 2017, but 2021, this was a data capture about halfway through the year. So we expect the volume has increased, and then significantly more so into this year also. We've had a lot more interest from the trans population looking at fertility preservation, egg freezing, and then IVF, even with the intent to carry pregnancy themselves, and ultimately for partner-assisted reproduction for cisgender female partner to carry the pregnancy. So we've definitely been seeing an interest, and notably, we had a large study that gave a lot of clarity and shed a lot of light on the potential to do IVF treatment and egg freezing after being on prior testosterone. So we've had a lot more patients coming in, I think, as a result of that, having that reassuring data. So for folks who are assigned male at birth, they are sperm producing, and there are multiple ways that they may be willing to produce sperm. If it's not too gender dysphoric for them, they can potentially consider ejaculation of sperm. However, alternatives like surgical retrieval or electroejaculation are also sort of alternative methods. We do recommend several months off gender affirming hormones, so off estrogens and any other hormones. Those are typically needed for a rebound of sperm production. Sperm quality, however, may be affected by prolonged estrogen administration. There's a couple of studies that have demonstrated that sperm counts can be decreased by as much as 50%. And it is possible that being on hormones for a very long period of time, there will not be a complete rebound of sperm production, in some cases, absence of sperm production in the ejaculate. So then surgical retrieval can also be considered at that time. For those with a female partner, or in particular, a person who is assigned female at birth with a uterus, they can consider intercourse if that's not too gender dysphoric, insemination with fresh or frozen thawed sperm, or alternatives depending on the sperm parameters. And those with a male partner, surrogacy with egg donation may be considered. For those assigned female at birth, they're typically egg producing, and depending on when they did the transition, they may have either frozen ovarian tissue or eggs prior to initiating testosterone therapy. Those individuals may choose to carry a pregnancy themselves at some point down the line, or potentially a partner or surrogate may carry the pregnancy. Lots of famous transgender males who have carried pregnancy before. I would say there's been some notable press around Logan Paul recently also carrying pregnancy, but of course we know that thousands of trans men have carried pregnancy. This is not a novel, but certainly maybe 5-10 years ago was more novel, but becoming more common as there are more and more people who are deciding to do this after taking a break from testosterone treatment. And oftentimes ovulation occurs very quickly for young patients who are coming off testosterone therapy. As a method of checking for reproductive testing or initiating fertility preservation, we often track the testosterone level. And even if patients are on high doses of intramuscular testosterone, their testosterone trends down pretty quickly, even in a matter of 2 to 4 weeks, and spontaneous ovulation can resume very quickly thereafter. Some specifics to share with you for working with the trans community. We have to be careful about using open, inclusive language and making sure everyone in our sort of community is well trained on the appropriate verbiage to use, and just having a kind of a trans inclusive environment. Insurance coverage has changed a lot, actually, and there's many of our Massachusetts insurance plans, so many of the sort of estate plans actually do have coverage for one cycle of fertility preservation. For trans women, that would include sperm freezing and freezing for some period of time, usually about a year. And for trans men, that would include egg freezing, including the medications that are involved. So it is, pretty great benefit. We do have the option of not inducing menses prior to treatment. And this is very important for trans men to be aware of because it can be very dysphoric to have red bleeding or vaginal bleeding in particular. And so there are ways to closely monitor for testosterone levels decreasing in order to allow for treatment start before having a period. And there are also considerations about stimulation, either by just decreasing testosterone dosing for a short period of time, or actually not stopping testosterone at all and doing an ovarian stimulation while on testosterone. So that's also being studied. Some things that are important to note is that trans men often have some degree of vaginal atrophy, so transabdominal ultrasounds can be really helpful to reduce any of the discomfort and the gender dysphoria that comes with typical monitoring for egg freezing. As well, in some cases, we can employ less frequent or more flexible monitoring, and a lot of this comes down to rapport with the medical provider as well. For example, for my patients who are undergoing fertility preservation, I always try to be there for their procedure for the egg freezing as we've established a rapport, and typically that creates a little bit more comfort for them going through the process. When it comes to family building for transgender individuals, of course, we're seeing societally more diagnosis and treatment of gender dysphoria at a younger age. And sometimes this is even before, folks are ready to start to think about family building. However, there are more and more studies that are even surveying teens, and many individuals have an interest in future family building. So it's always important to counsel before, fully transitioning about the treatment options that are available and fertility preservation. An older study, this is actually published in 2011 before ASRM lifted the experimental ban on egg freezing. This is for men, trans men who had undergone gender affirming surgery. this is looking at their sort of sense of regret, or trying to establish whether they had got any sense of regret about not having gone through any sort of fertility treatment prior to having removal of gonads. In this population, about 2/3 were in a relationship, and about 1/5, about 22%, already had children previously. And over 50% really at this point reported a current desire to have children. And most in this cohort had already had an oophorectomy and didn't have that option any longer. And 37% reported that they would have considered freezing their gametes had the option been available to them. So we know from this study, and then some later studies looking at all wide ranges of ages, that there is a strong interest in family building, keeping options open, and considering fertility preservation. So in an additional study, 39% had current or future parental desire. And interestingly, only 9% had actually cryopreserved reproductive cells. And there was a lot of reasons, a lot of barriers potentially to fulfilling parental desire. And you know, this is something that we hear a lot from patients who you know, who come to us. But ultimately, most people who come in for consideration of fertility preservation will actually end up proceeding with treatment. Now, moving forward to our study. This is a study that was published in Fertility and Sterility in 2019. This study looked at assisted reproductive technology outcomes in female-to-male transgender patients. And we actually compared them with cisgender patients, so heterosexual patients undergoing IVF. And we really call this a new frontier in reproductive medicine. It had previously not been studied in any sort of a larger format a case series. So we were very proud to be able to educate other individuals or other providers in the field who maybe had not worked with such a large population. And I think this data set was very informative. So this was an electronic database search over an 8-year period reviewed by the IRB at the BI. And it was basically inclusive of all transgender men who had completed an egg retrieval for the purposes of egg freezing, creating embryos, or actually an intended uterine transfer. So we actually looked back at how many patients had gone through for a discussion about this process, and about half of them underwent treatment. This is pretty consistent with data also from pediatric or adolescent consultations for fertility preservation. About half of folks who present for discussion will end up going through treatment. And we had a total of 29 cycles completed by 26 patients. Since that time, in the last 4 years, we've approximately tripled our experience with working with transgender individuals, which is just really, really amazing how many more people are interested in completing treatment. The time and testosterone prior to seeking ART treatment varied from 3 months to 17 years. So we have had individuals who've been on treatment for a very long period of time. And the average time they had been off testosterone was 1 to 12 months prior to treatment. So our results. So average age of our patients was 28. Average age of those pursuing egg freezing was 25. And those pursuing embryo freezing were a little bit older, 32 or 36 respectively, depending on whether they intended for a transfer. The number of eggs retrieved was on average 19. The highest, of course, in our youngest age group, those seeking fertility preservation through egg freezing, 22 eggs. And then the lowest in those who were seeking IVF with ultimate embryo transfer. Those are also the most likely to have a history of infertility and prior unsuccessful treatment with donor insemination. We then matched patients by age, body mass index, and AMH across our heterosexual population, cisgender patients. And interestingly, we found that the number of eggs were actually greater in those transgender patients, even with prior androgen or testosterone exposure. So in the cisgender group, in the well-matched age group, the number of eggs were 14 on average, and in the transgender group, 18 on average. And what was notable is that we ended up using higher doses of injectable hormones to stimulate the ovaries of transgender individuals, but the outcomes correspondingly were very reassuring, with a high number of eggs and a high number of mature eggs. At that time, this was really the first study of its kind, and it really offered a descriptive approach for other providers in the field. Limitations is there's still a pretty small number of patients, though we've continued to look into our data and have put out further studies looking at the safety of this type of procedure. And it seems to be that a lot more studies are coming out from centers across the country as well that all show kind of similarly reassuring data. And then in terms of a follow-up, we looked at some additional information about folks who have been on testosterone for longer periods of time and whether that had an impact. And some of our bar graphs here show that there was not a meaningful impact on the number of eggs retrieved, even if individuals had been on testosterone for a longer period of time. Okay, so just to wrap up here, thank you so much for your attention. I want to leave about 10 minutes for questions. So the last thing I just wanted to share with you is that when you refer a patient to Boston IVF, it's important for you to know what happens. Well, they call us and they speak to our centralized booking center. They're scheduled for an hour initial consultation, either with a reproductive endocrinologist like myself or one of our nurse practitioners or PAs in order to permit for expedited booking. They're scheduled for some initial testing. If they are regularly cycling, they can have this done with their next menstrual cycle. If they're not cycling or they're on testosterone or some other hormones, they may either do so while they continue on that treatment, or they may choose to come off with the intent of proceeding with treatment thereafter. And then depending on their history, they may be offered some additional support services like our social work, counseling, nutrition counseling, acupuncture, and other wellness treatments that are offered through our center. For treatment timelines, typically for those assigned female at birth, typically the testing takes about 1 month to complete, about a one month process for insurance coverage, getting prior authorization through insurance, and then most treatment timelines are about a month. And on this slide, for those who are interested in using surrogacy, the treatments take about 1 to 2 months, but the surrogacy matching process used to be about 6 to 9 months. We're seeing something closer to 12 to 18 months now, particularly past Roe v. Wade. So lastly, I just want to let you all know that what you put out there for your patients is very important. You know, we are an LGBTQ plus friendly practice. We're very proud of that. We do a lot of work in training our staff in order to make sure that everyone has a good experience, and putting that out there on your websites, and making sure that you have inclusive restrooms, inclusive documentation. That's all really important. And we hope to take great care of your patients. So let us know if we can help. Thank you so much for your attention. Again, I hope that we've met our objectives for today. Thank you. Here are my references, and I would love to take any questions from the audience before we wrap up today.
Thank you, Dr. Resetkova. We're now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Resetkova, our first question is, at what age would it be possible for sperm banking for a patient who may be considering going on estrogen?
That's a great question. Sperm banking can be done really at any point, once the child is able to ejaculate a sperm sample. That can be dysphoric to some individuals, so it's something that they would have to really be comfortable with and be counseled about. I have had patients as young as 12 to 14 bank sperm successfully. One thing to consider is that they may need multiple attempts in order to collect a sample that ultimately is strong enough essentially to be used as a backup sperm sample or as a cryopreserved sperm sample. So it may be a multi attempt. But at the end of the day, usually we recommend for banking about 10 or more vials, and that's really in line with the guidelines for fertility preservation. So banking for cancer patients as well, we would look to something similar. So 10 or more vials, and usually that can be done over the course of 1, 2, or 3 ejaculatory attempts.
Thank you. The next question is, for patients in this community, if they have no experience with, like, say, infertility, should they come with some testing, or do you recommend us doing testing, or should they come first, I guess? Yeah.
Yeah, I mean, it's a great question. Usually patients without a history of infertility, it's probably best that they do all their testing at the fertility clinic, particularly if they have, insurance that permits that. I would recommend that they do that, because then it sort of decreases any of the sort of need for unnecessary or duplicate testing, and they can probably do it a little bit faster with us, where we're open 365. We're open on the weekends and holidays, so we can accommodate for cycles that occur over the weekend as well. So I think probably best for a non-infertile patient just to come and have their full workup and evaluation at Boston IVF, and then they can also have the counseling about any of the testing and have any questions answered before kind of starting on that pathway. And if any testing can be deferred, or if they're uncomfortable with any of the testing, we can talk about pros and cons of that as well.
Great, thank you. That was our last question. Thank you, Dr. Resetkova, and thank you everyone for attending today's webinar, LGBTQ+ Family Building. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on today's presentation, and we would appreciate it if you can complete the survey to provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to review a recording of today's webinar. On behalf of Boston IVF and Dr. Resetkova, thank you for joining us today, and enjoy the rest of your day. Thank you, Dr. Resetkova.
Thank you. Bye, everyone.